Assalamu alaikum wa rahmatullah. Welcome everybody. It's very nice to have you tonight for our session. Most of you know me. I'm Majed Alghamdi. I'm a consultant radiation oncologist. I have two announcements to make before we hand the mic to Dr. Ibrahim Al-Otain. So the first thing is we are trying to get CME credit hours for our meetings. Inshallah, not sure about this one. Likely we will get it, but we'll try. But inshallah, for future meetings, we will get some CME hours, a couple hours probably, thanks to Prof. Yasser Bahadur and Dr. Ibrahim Al-Otain. So I will send a form actually for registration in the chat, so you can click on that form and you can fill in your information, so that if we get the CME hours, then you can be credited for the total number of hours for the session. The other announcement is that although we were planning to have Dr. Adnan as a moderator so that we can learn from him and get him involved more in discussion, but for whatever reason he couldn't make it as a moderator. But we're glad to have him today as a attendee with us, inshallah, and he will enrich our discussion bismillah. So our topic today is about management of brain metastases, multiple brain metastases, between stereotactic and whole brain radiation. Our speaker today is Dr. Ibrahim Al-Otain. He's a consultant radiation oncologist at King Fahad Specialist Hospital in Dammam. And he did his residency training at Henry Kaplan Cancer Center in Tours, France, and two fellowships in Canada, in neuro-oncology and radiosurgery at Montreal, McGill, and another fellowship at Princess Margaret Cancer Center, University of Toronto in head and neck. So he's specialized in our topic today, and it's my pleasure to have the chance to introduce him and to give him the chance now to start the presentation. Dr. Ibrahim.
Thank you, Dr. Majed. Thank you, Dr. Majed, for the kind introduction, and thanks for the invitation of the SARO Rounds committee. And so today I'll be talking about management of multiple brain metastases with a focus, inshallah, on stereotactic versus whole brain. And inshallah, we'll try to stick to time, around probably 25 minutes. We'll go through multiple important things in the management. If you allow me, before we start, I will ask Dr. Majed to give you a quick poll questions to see your practice. And I would like you please to participate. The first question is gonna be, what is your cutoff for the maximum number of brain metastases that you will treat with SRS? 4 brain metastases, less than 15, or number doesn't matter. This is the first question. Second question is more easy. What prognostic scoring system do you use? RPA or GPA, or I don't use any? And the last question is simply saying, do you use Memantin or hippocampal sparing techniques to preserve cognitive function when giving whole brain radiotherapy? These are the 3 questions. All you need is to pick up one answer and press submit. I hope everyone has the time to do it. خلاص? Majed probably will carry on. شرايك?
Yeah, sure.
So a quick introduction. Let me go back to my screen. As you know, the brain metastasis is actually... Sorry? brain metastasis is, Dr. Majed, can you mute everyone for now? Is that?
Dr. Ibrahim, unmute yourself because I muted everybody.
Okay, very good. So brain metastasis is a very common problem. It's probably the most common intracranial problem. It happens in more than 30% of our patients with solid tumors. And we seems to have more and more patients nowadays, probably because of better imaging, early detection, and better outcome in the survival. And if you see the incidence, as you know, varies according to the histology. Lung is probably the most common, followed by breast, and there are more rare tumors to get brain metastasis, typically head and neck tumors. These tumors usually present as ring-enhancing lesions with perilesional edema. Some of them are hemorrhagic, typically hemorrhagic, and we usually see that with melanomas, renal cell, or thyroid. We'll come to the management. As you know, the treatment options varies between stereotactic radiotherapy, whole brain, surgery, systemic treatment with supportive care. And to be honest, the standard of care for many, many years for multiple brain metastases used to be whole brain. But nowadays we have a shift, a paradigm shift in the practice toward the stereotactic radiotherapy. And in the coming few slides, I'll try to show you this. So whole brain or stereotactic radiotherapy. Let's start with patients with less than 4 brain metastases. We know for this kind of patients, 1 to 4 brain metastases, that the Japanese trial, the landmark trial in 2006, actually compared patients, randomized patient to either stereotactic radiotherapy or the same stereotactic but with the addition of whole brain radiotherapy. And what we know for a fact that adding whole brain radiotherapy for these patients does not improve the survival. It does improve the intracranial local control, but it doesn't improve the survival. Similar result was shown in the European trial, a bigger trial with bigger number of patients, probably the similar design in the arm of stereotactic radiotherapy. In either they were randomized either to whole brain or observation, and the same result. Adding radiotherapy to SRS does not improve the survival. It does improve the intracranial control, but without an improvement in the overall survival. So one might say, oh, there is an advantage, although there's no improvement in overall survival, but has some advantage in local control. And in fact, this is coming with the cost of neurocognitive function. If you see this trial, Chang, the MD Anderson trial, they were trying to do similar design like the previous ones, but with the primary endpoint, or they were interested in the neurocognitive function. And this study actually stopped early because of severe deterioration of the cognitive function. This data was more clear in the Alliance trial, which published in 2016, which clearly showed that adding whole brain for this kind of patients with limited number, 1 to 3, actually didn't improve the survival, but it did worsen the cognitive function. And these data make it very, very clear and change our practice for these patients and made SRS as a preferred option for patients with limited number of metastases. What about patients with more than 4 brain metastases? Now, less than 4, we know the preferred option for sure is stereotactic radiotherapy. But what about patients with more than 4 brain metastases? We learned from this multi-institutional prospective observational Japanese trial that took more than 1,000 patients who were treated with stereotactic radiotherapy and looked into their survival. What they found that there was no difference between the overall survival for patients with 2 to 4 versus 5 to 10, meaning that they are similar to patients with less than 4. And it means that we can offer them SRS alone, similar to what we do for patients with less than 4. Other data, a big multi-institutional experience data published in 2019 in the Red Journal, taken about more than 2,000 patients, all treated with initial SRS, and we looked into the overall survival. And again, there was no difference between patients of 2 to 4 and 5 to 15 brain metastases. So probably up to 15 brain metastases, it is okay to treat them with a stereotactic radiotherapy, and if you do so, you are not affecting at least their overall survival. Although these data were either retrospective or observational data in the Japanese trial, it was enough to make SRS as a valid option for patients with extensive brain metastases. But nowadays we have a more solid data. Looking into this phase 3 randomized trial for patients with 4 to 15 brain metastases. This is the one which was presented in the last Astro a couple of months ago. This is one-to-one randomization trial comparing SRS versus whole brain, with the primary endpoint of the neurocognitive function presented by memory function at 4 months, measured by Hopkins Verbal Learning Test, total recall, and local control. And to make it short, what we found is actually there was a severe deterioration in the cognitive functions in patients with the whole brain. And there was no improvement or no changes in the overall survival. So actually, if you compare stereotactic radiotherapy versus whole brain radiotherapy for patients with 4 to 15 brain metastases, you will find that they have similar overall survival, but clearly patients who were treated with whole brain, they will have much worsened cognitive functions. So this is a level 1 evidence that support the use of stereotactic radiotherapy for patients with multiple brain metastases up to 15 brain mets. The question is, what is the cutoff? Can we say that 15 brain metastases is the maximum number that we can go in? Is it 15? Is it 20? Is it more than that or less? Probably you can treat more than that easily if you can. Looking into this example, I took it from one recent publication. This is a patient with 30 brain metastases who were treated with LINAC-based treatment, VMAT. And interestingly, the dose that received to the hippocampus was less than 4 Gray. It's even less than what we usually do in doing the hippocampal sparing whole brain radiotherapy. Very good outcomes with 5 VMAT arcs. So whole brain or radiotherapy, probably they are more than the number of brain metastases we need to look at. And this will take us to the prognosis and prognostic factors, because as you know, prognosis is very helpful in decision-making process for these patients. There are many important prognostic factors, including age, performance status, the burden of the disease, the tumor type and molecular markers, etc. Historically, we used to use the RBA, which is a simple classification from 1 to 3. 1 is good survival, 3 is bad survival. But as you know, RBA does not include the tumor subtype or the molecular markers. But nowadays, we have the GBA, which does include the molecular types, and it's actually more updated. It is, again, not very complex. It's very simple. It is from 0 to 4. 4 is the best prognosis, and 0 is the worst one. It's so easy because nowadays it is available online. And this link here, all you need to do is go to the site and enter a few data, and you will get the GPA score and the estimated median survival. Here, an example of a patient. I did it myself. It's a patient with breast cancer. She's 40 years old, which is less than 60. She's in very good performance status. She's triple negative patient. She has multiple meds, more than one, multiple, and she has active extracranial disease. Her GPA was 1.5, and his estimated survival was about 13 months. I took the same characteristics of patient, but the only thing I changed was her tumor subtype. So the first example was this patient, but she was triple negative. This one, the same patient, but I made it triple positive. And as you can see, the survival jumped into 23.5 months with a GPA of 3. Very simple, and I advise you to go and try. There are other important factors, and probably the most interesting one is the cumulative intracranial tumor volume. This is probably the game changer one. And we know from this study and others that the total tumor volume, it's actually probably more important as a prognostic factors than many others, including the number of metastases. Here you can see many retrospective trials and the multivariant analysis comparing volume of metastases versus a number of meds. And as you can see, in many of them, the volume, the total tumor volume, the volume of metastasis was more significant in estimating the overall survival than the number of meds. And actually, if you see the latest NCCN guidelines, actually tumor volume was considered. If you read whatever written there under the chart, it says that SRS for, we're talking here for extensive brain metastasis patients, SRS can be considered for patients with good performance status and low overall tumor volume. So it's a valid prognostic factor. The issue with the cumulative intracranial tumor volume actually is what is the appropriate cutoff. When we say this is a very high volume, tumor volume, and probably whole brain is more suitable rather than SRS. Actually, it's not well defined. The previous Japanese trial, the one taken 1,000 patients and comparing the overall survival of two groups, actually they took patients up to 15 cc total tumor volume. But there are many other studies, including the one I just showed you in 2019 with 2,000 patients. Actually, this trial took patients with bigger total tumor volume up to 30 cc. And if you look into the Canadian trial, the one we will be waiting for, because this is the one which will compare actually stereotactic versus hippocampal sparing whole brain radiotherapy plus Memantin. This is going to be a Canadian Alliance Energy trial, David Robert trial. And actually in this trial, they will allow patients with maximum tumor volume up to 30 cubic centimeter. So if you ask me, I would say 15 to 30 is reasonable, but more than that, probably it's not a small tumor volume. So what about fractionation? What fractionation should we use? We know fractionated is quite a common concept. It's easy, especially for people doing LINAC-based stereotactic radiotherapy. A small number of side effects, etc. The most common probably fractionation is 27-3 and 30-5. The Maniti trial is a very interesting trial because this one showed a better local control using the fractionated radiotherapy, stereotactic radiotherapy. He used 27-3 versus single dose stereotactic radiotherapy for lesions, for large lesions, more than 2 centimeters. And he found that this one, the fractionated one, gave him a local control of around 91%. I personally do 13-5 because this is what I was trained with. And actually, if you're looking into this data, actually 13-5 gives you similar local control around 91%. So it's a good one and can be used for large brain metastases. Quick things about a whole brain. Probably if you use it as we know, as recommended. We know Memantin was probably, the data was published by Brown in 2013, though it's not widely used. Here we're looking into the SEER data, examining the usage of Memantin for brain metastasis patients, and apparently even with the publication of the R2G0614, only 5% of patients are getting Memantin. Probably after 2016, probably it's more, but still it's quite minimal. I don't know how many of us are actually using Memantin for patients with whole brain. Nowadays, since 2018, we have the NRG CC001, and the standard of care nowadays for our patients is hippocampal avoidance, whole brain, plus Memantin. So I recommend you guys, if you are doing whole brain, probably you should do it with the hippocampal sparing technique plus Memantin. Just a quick, probably 2 slides about supportive care. From my understanding, supportive care alone is not widely used in our practice. Probably we think twice or 3 times for declining any patient who was referred to us for whole brain radiotherapy. And I remind you that we have a very solid data, the QUADS trial. We took patients with the non-small cell lung cancer patients, not eligible for surgery or stereo, and they randomized them to either supportive care or supportive care plus whole brain, 20-5. And we all know the results. Whole brain plus supportive care did not improve the survival and did not improve the quality of life. I know patients in this trial, they were a very poor performance status patients. The median survival actually in both arms of the study did not exceed 2 months. So these patients with the overall survival of 2 months, it's really poor patients. But it actually tells us that if you see a patient with poor performance, uncontrolled extracranial disease, he does not have a lot of systemic treatment options, probably this supportive care would be a very reasonable option for him. And I'm just showing you here a response from an expert in CNS and brain metastasis. And he actually the author of the CC001 trial, NRG trial, the hippocampal sparing. He was asked about his practice about hippocampal sparing, and he said this response was prepared by him and Dr. Gandhi, the one who presented the data on the Astro meeting. And apparently what they do there is actually this. They don't offer whole brain radiotherapy for patients with poor prognosis, who present with poor performance status, asymptomatic brain mets, or limited systemic therapy options. With this, I'll stop here and thank you for listening. Thank you.
Thank you very much, Dr. Ibrahim. This was an amazing lecture. Do you hear me?
Yes.
Okay, great. So yeah, thanks for this informative presentation. And just before I open the discussion, just a few things, a few points maybe to summarize everything here is that it seems like WBRT or whole brain irradiation is certainly falling out of favor for limited brain metastasis 1 to 4, let's say 1 to 4. What we are debating about and what everybody is discussing nowadays is actually more than 5. So 5 or more brain metastasis is where we don't have certain answers whether stereotactic is better than WBRT, especially with the hippocampal avoidance or not. But for limited brain metastasis, certainly 1 to 4 is stereotactic is really gaining more attention and becoming the standard of care, if not already became standard of care in some areas. Now, unless there is leptomeningeal disease. Now, the other thing is the question that Dr. Ibrahim raised about should we consider the absolute number of metastases to call it limited or extensive, or the volume. This is debatable, and still, as he illustrated, it's going to take some time until we settle down on fixed figures for these issues. But until then, the volume makes sense actually to use the cutoff volume of cumulative 15 cc for all brain metastases, which means that even if you have 50 brain metastases, but all of them are tiny and they're not going to go away with systemic therapy, then I don't know, but it has been done, right? So it makes more sense to give stereotactic than, unless you have issues, of course, with the workflow and all of these things. And now the last thing is the hippocampal avoidance. If at all you want to consider WBRT, whole brain radiation, then it's probably also becoming a standard of care hippocampal avoidance. And I think the neurocognitive dysfunction that Dr. Ibrahim mentioned is serious. It has been shown in about 4 randomized trials. So we have level 1 evidence of showing the detrimental effect of WBRT on the memory. And this is actually happens. This happens on 4 months, during the 4 months of the after the treatment. So this is very short time. And if you have patients, he's already overwhelmed with so many things ongoing, and the last thing you don't want to do to him is actually impairing his memory, short-term memory. So I think this is important for quality of life consideration. So with that, I'll come back with some questions to Dr. Ibrahim. But before that, if anybody, please let us know if you have any points you want to comment on, or if you have any questions to Ibrahim.
Majed, before
yes,
before opening the floor for questions, I would like to hear from our experts. I don't know if Dr. People who are doing stereotactic radiotherapy and dealing with brain metastases. I think Dr. Adnan is around, and maybe Dr. Yasser, Dr. Khalid, Balaraj, our experts here. I would like to hear their practice and what do they do and what do they think about it, if possible. Probably start with Dr. Adnan if he's still with us.
Okay, let's move into the. Yeah, sure. Yeah, please, Dr. Adnan. Yeah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, I was listening to Paul Brown in one of his lectures in 2015 in one of the ASCO meeting. I cannot remember really. If you go in detail about the hippocampal verbal learning test, it is almost 5 or 6 questions or 6 parameters. One about the fluence, one about the memory, and the others I cannot remember really. not in all parameters, the whole brain radiation therapy was involved. I mean, there is a significant data that it affected in the verbal learning test. Unfortunately, in the past, all the studies was done by mantle test. I know mantle test, not like verbal learning test. I am not the one who is going to question the randomized clinical trial, but I feel that if you want to treat 15 brain metastases with the CyberKnife, for example, I think you will treat the patient for the whole day. It is not that fast treatment, by the way, in CyberKnife, which is dedicated machine for stereotactic radiosurgery. Also, the same situation if you have linear accelerator. Those kind of treatment may be good for gamma knife stereotactic radiosurgery because you can treat the whole lesions at once. Just the collimators will move automatically and treat all the small lesions. Not all the patient the same. The recursive partitioning analysis and the GBA, they didn't discuss the location of the disease, for example. Nowadays, I have a case, the metastasis in the internal capsule, giving 27 gray will cause necrosis to the internal capsule, so the patient will end up with hemiplegia. So sometimes you need to think, what is the best for them? My patient actually, she's a performance status 3+, liver metastasis, lung metastasis, but she's young, she's 49, and she's walkie-talkie. I told her, my treatment, I will treat you with stereotactic radiosurgery, but maybe down the road you will have necrosis. I told the patient, what do you like? Do you like decrease in cognitive function, early memory, not fluent in your speech with whole brain radiation? I saw complete response with whole brain radiation therapy. I saw also complete response with stereotactic radiosurgery, but nobody addressed the toxicity of stereotactic. Actually, giving 27 gray in 3 fractions, this will cause necrosis in the side. It's not all the time you are treating only the tumor cells, you are treating brain parenchyma as well. So if the disease in the motor area, definitely you are causing some problem. I saw patients with edema. They came to the emergency really in bad shape after stereotactic radiosurgery. Not addressing the toxicity of the stereotactic radiosurgery in those studies give me a really big question mark. Why? There is no toxicity for stereotactic? No, there is a lot. They just compare initially all the studies, just they want to tell us that whole brain radiation therapy not improving survival. Be careful. And they want to kick it out. Nobody accepts that. So at the end, they said, no, let's find another parameter. Oh, cognitive function, very important thing. They started with mental test. And Aoyama, one of the first study presented by Dr.
Am I the only one who lost Dr. Adnan, or?
I lost him too.
Yeah, we all lost him, I guess.
Yeah, okay. Let's hope he comes back soon, inshallah. But yeah, his point is very well taken, and I see where he's coming from. And actually, one of the studies showed 20%, more than 20% necrosis with 20 gray or more single fraction stereotactic.
That's why we fractionate, Majed. That's why.
That's true. So it comes with toxicity, and especially, and the other factor that I think, and I will mention this to Dr. Adnan as well, is that
who cut me?
Yeah, Dr. Adnan.
I was really enthusiastic. Everything.
Dr. Adnan, I think it's Majed who did it in beta.
Or the sponsor, maybe Accuray or one of the gamma knife.
Accuray, CyberKnife.
Interesting. What I want to say about the, I forgot what I was talking about really, about the toxicity of the stereotactic. There is toxicity. Yeah, about the Aoyama. Aoyama said that the relapse, which is up to 50%, by the way. So you need to follow the patient every 2 to 3 months with MRI. And this is not available in each hospital. And this will cost a lot of money. Not every patient will do MRI every 3 months. But if you give him whole brain radiation therapy, this will be because you proved, the randomized clinical trial proved that whole brain radiation therapy will decrease the relapse in the brain. So I think, I know Adnan cannot fight against a lot of randomized clinical trials, but really in the real life, I feel that whole brain radiation therapy still valid option. And I think sometimes we need to invite the patient opinion, or we should ask the patient if he like to come regularly with the MRI and to give him the stereotactic radiosurgery and the side effects of the dexamethasone, which usually prescribed in brain edema after stereotactic radiosurgery. This is not addressed in all the trials. I don't know why. But whole brain radiation therapy, safe, no need for steroids, and the patient will tolerate it very nicely, very cheap, no need for regular follow-up with MRI. Thank you very much.
Yeah, thank you, Dr. Adnan. It's very well taken comment, and actually, it's not only you. This is, I mean, so many big names in our community. They are saying exactly the same thing. And I was just saying that in one of the studies, like necrosis was more than 20% with the stereotactic, especially with single fraction. So it is not always safe for sure. But the thing is, what I noticed is that we are not aggressive in treating possible necrosis after treatment. So from what I observed in North America, let's say, they are so aggressive in treating whatever they thought it's necrosis after treatment with the stereotactic. So they always give prophylactic dexamethasone, they increase the dose, they watch the patient, they do more imaging. And as you mentioned, this is time consuming and everything, not very convenient to the patient. But also they would prescribe Avastin. There's not that much of huge evidence, but they do, and they observe some meaningful responses in their opinion. They prescribe Avastin. They also get surgeons involved if they have to do some sort of decompression or whatever for the radiation after radiation necrosis. So they do have in place kind of workflow for the radiation necrosis treatment. So I agree with you. If somebody is not comfortable with doing the radiation toxicity side of it, or you didn't have team, you didn't have resources, you didn't have surgeon to back you up, you didn't have, it can be lethal, especially if it happens in the posterior fossa, as you know. And if you don't have medical oncologist who's willing to give Avastin, for example, or so I take your point, and totally reasonable for sure. But on the other hand, let me ask you, Dr. Adnan, before we switch there, would you consider fractionation? So if you're not happy with the 27-in-3, as you mentioned, the Minetti Italian regimen, it is associated with more necrosis in retrospective data compared to, of course, the 5 fractions. So what I observed in Canada, they do actually 5 fractions. So they choose 25 gray until 32.5 gray over 5 fractions. So they tend to fractionate more, especially if the size of the lesion or location, as you mentioned, is critical, or the size is big. So they fractionate to get lower risk of necrosis. Would you consider fractionation other than 27-in-5, Dr. Adnan?
I part of the question not here because I was lost connection.
Yeah, my question was, and very quick, would you consider the 27-in-3? We get your point. It's not toxic. It's probably toxic, but the thing is, would you consider 5 fractions as it's more common in North America? They use 5 fractions, 25 up to 32.5 gray in 5 fractions to minimize the risk of necrosis. Have you tried that? Or?
Yes, me and Dr. Majed and stereotactic radiosurgery, if it is more than 1, we usually fractionate. And we prefer the 3 fractions every other day. But now with the 30-in-5, really more attractive to me because it will be. But by the way, in the Eastern province, because most of our patients coming from far, either from Al-Hassa or from Qatif or something, so if it is every other day, it's easier for them. But I will consider the 30-in-5 if it is 91%, as Dr. Al-Otain mentioned.
Well, Dr. Adnan, this is what we use during training in ساني بروك يعني بالذات they have very good experience with this fractionation which seems to be working. وفي as you say the macro data هذه published في Red Journal limited number of patients but very good local control يعني 91%. It seems to be an excellent يعني choice.
By the way, nobody discussed in the data how many times the patient come to the emergency complaining of headache and edema, admitted for IV steroids. This is really a lot of money, by the way, to the hospital. But still, the whole brain radiation therapy, yes, I admit it will affect the cognitive function. By the way, there was in the Mantle test era, there is some improvement in the cognitive function after 1 year. If you look closely to do study, they measure the cognitive function after 3 months and after 6 months. Nobody measured it after 1 year. And if there is improvement, that's mean it is not permanent damage to the cognitive function. It is just temporary. There is a study, but not Hopkins verbal learning test. It is by Mantle test. It showed that the cognitive function improved after 1 year. And this is really good data. If somebody did this cognitive function test after 1 year for those patients, I will put my 10 fingers on this study. This is really good. But after 6 months and that's it, why? We want after 1 year. But most of the patients, because they will not survive, they have a lot of excuses to say no.
Okay, thank you, Dr. Adnan. We'll come back to you when we discuss the alternatives to stereotactic, a whole brain with hippocampal, without hippocampal, and your input on this. So anybody, yes, Prof. Yasser, please.
Okay, I would like to thank you, Ibrahim. MashaAllah, very informative presentation, and we really enjoyed the debate with Majed and Adnan. It was very learning for us. I know the subject is quite big, but I want to ask you, Ibrahim, about the role of surgery, and when you consider a patient with solitary metastases, when you consider surgery, and then what's your recommendation post-operative for whether SRS to the surgical bed or whole brain?
Thank you, Professor Yasser, for the question and for the compliment. So, the role of SRS, the role of surgery, sorry. Role of surgery in case of single brain metastasis, I think it's a standard of care. If you can't take it out, you should take it out based on the Bachelor, يعني the landmark trial. Still surgery followed by stereotactic radiotherapy if possible. Although in many of our patients, surgery, upfront surgery might not be possible, or it has a lot of consequences, including delaying the systemic treatment. So stereotactic radiotherapy alone, radical stereotactic radiotherapy, it seems to be a very valid option for patients with single brain metastasis. Now, if you operate, I agree with you, if you operate, you can give stereotactic radiotherapy at the surgical cavity. We have a lot of data and solid data. And in my practice, I use the same fractionation. I use fractionated, I use LINAC based. I don't have a CyberKnife or Gamma knife. So I use only VMAT, LINAC based, and I use fractionated radiotherapy, same fractionation, same 13.5. I don't know if Majed has different, or Adnan, or you, Dr. Yasser, if you have different.
Yeah, I do the same thing, actually, Ibrahim. I do the same thing. I do treat the post-operatively with fractionated stereotactic. So, and this is based on what I was trained on, but we don't use a single fraction for post-operative cavity. It's always 5 fractions, and we use the same, as you said, the same doses, and a LINAC based mostly. And then let me ask Iman Alhebshi, because she's doing same thing probably. Iman? All right. Okay.
According to the cavity size, if the cavity size less than 2 centimeters, I used to give single fraction 20 gray after complete excision. But the patients still need regular follow-up with MRI, like the stereotactic radiosurgery. But no whole brain radiation therapy as their PET-shell, which one of the studies which showed improved survival in good performance status patients.
المشكلة دكتور عدنان، المشكلة السيرجيكال كافيتي دائما تجي أكبر من التيومر itself. عارف دكتور عدنان، دائما تجي bigger than.
You are right.
Yeah, Ibrahim, do we have any study that comparing the whole brain plus surgery versus only stereotactic plus surgery?
في بروف دكتور خالد، في يعني if you take a randomized European trial, I'll try to pull it off now. دقيقة دكتور خالد. If you take this, عفوا منك. This is, I don't think we have randomized things to compare this. بس هنا ايوه تفضل معي.
لا sorry, go on.
ايوه هنا it was a comparison between upfront stereotactic radiotherapy or surgery. طبعا هنا multiple brain metastases. بعدين
and this study, if I can add, in this study, the arm when they compared surgery versus SRS, there was no difference. So it was SRS or upfront SRS or surgery was used, like you can say exchangeably or interchangeably or whatever. So it was either or, right? So but it wasn't designed to compare, I think, between these arms. But
بس ايوه دكتور خالد ما عندنا يعني big data، بس looking into something دكتور خالد هنا الله يطول لي عمرك، looking into هنا relapse rate after surgery after SRS. You know after surgery after SRS relapse يعني يعني شو اسمه high، بس شو اسمه after surgery دكتور relapse was in the trial was 59%.
No, what I meant is surgery followed by whole brain versus surgery followed by stereotactic. There's no trial comparing these.
I don't think there's any, and there will be no, because I think, in my opinion, the trend now is to get rid of the whole brain or do it with all of the hippocampal avoidance. So I don't think there will be, and the thinking now is that SRS, we don't have evidence, but SRS is equivalent to surgery for single, small, it's almost the same based on retrospective data, but there's no level 1 evidence head-to-head comparison.
Okay, so in Tawam, what we have a 21XI rapid arc variant, and there's no high definition MLC. It's 5 millimeter MLC size. So we did not start yet stereotactic. We're pursuing our dedicated machine now, inshallah. But what we use is for 1 to 4 definitely. Now all the evidence support that stereotactic is better than whole brain irradiation. We're using something called SIB. We used to give whole brain radiation therapy plus concentrating on the tumor itself is three tumors with less or 1 centimeter or less, 40 gray. So we're giving stimulus, SIB stimulus, integrated boost. For more than 4, still we're using whole brain irradiation with hippocampus sparing. If we assume that we have only 10, which is average between 5 and 15, and if we get 1 centimeter size tumor, you will end by treating the whole brain with a stereotactic radiosurgery. So you're giving high dose per fraction. If you say 27 and 3, this is almost how much? I don't know. It will be 8 gray per fraction to 10 lesions. So you will end by having very high dose to the whole brain. I don't know. There's uncertainty for more than 4. The jury is not answered, but for 1 to 4, definitely the evidence supporting stereotactic radiosurgery.
Sure, thank you, Dr. Khalid. But so is that true that you're still using the integrated boost, simultaneous integrated boost, like whole brain, and then you boost it with SRS, or?
Yeah, unfortunately, still, I know that is not the best modality, but because of we don't have the capability of doing the stereotactic, we're using this, and we find it good in our patient. To be honest, I don't find a definite cognitive function, obvious cognitive function loss when I compared my patients who received the whole brain versus both of them together.
And you spare the hippocampus currently,
yes.
or you have
Yes.
Nice. Do you have anything, Ibrahim, to show us here?
Dr. Majed, I remember during my residency, I used to recruit patients for the Canadian trial. حقت London, Ontario, if you know it. كان فيها tomotherapy whole brain with SIP boost to the tumor. Now, this slide will just show you VMAT treatment for patients with 30 brain metastases. 30 بس طبعا small tumors, يعني total volume was only 4.7 cc, يعني small tumor.
What kind of multi-leaf collimators do you use in these very small lesions, Ibrahim?
أنا in my practice I have the same as Dr. Khalid. يعني أنا في الدمام I have only 5 millimeter MLCs, so I don't have the high definition ones. And,
but really, this plan really difficult without micro multi-leaf collimators.
I understand. I agree معك هذه 30.
Any lesion less than 1 centimeter cannot be treated with our multi-leaf collimators. It should be micro multi-leaf. This is what we have difficulties with our cases, actually, with our physicists. So we will wait for the disease till it reach 1 centimeter to treat. I'm joking. Otherwise, you will treat part of the brain unnecessarily.
No,
and this is actually one of
they treat this with tomotherapy, not with Linac.
Tomo. Oh,
yeah. This is Tomo, not Linac. Yeah.
Even Tomo cannot do this very small, I think. I don't know, but this is really tiny. This can be treated by cyber knife or gamma knife, or micro multi-leaf collimators.
هذه لينك based بس ما هو مكتوب what type of MLCs لأنها small lesions.
Yeah, if it is
Linux based, very Linux based.
Yeah, we do Linux based, but the problem is the size is mattering for those kind of cases. Really, it should be micro multi-leaf collimators. I think Faisal Specials, we use the micro multi.
Yeah, agree with you, Adnan. Less than 1 centimeter, you cannot achieve it with 5 millimeter MLC. It'll be difficult.
Very nice. Yeah, thank you, Dr. Adnan. Thank you, Dr. Khalid, Dr. Yasser, and everybody. We only have 4 minutes, but we still can have maybe a couple of questions if anybody has.
Yes, I have a question. The memantine comes at 10 milligram tablets. Is that right? So the data usually about 20 milligrams. And somebody will ask for how many days, just during the radiation stereotactic, or you will continue for weeks after that, just to complete the memantine advantage. And if anybody have a new clue how it works, I would be very happy. Is it a scavenger? A scavenger? I don't know.
Ibrahim, do you want to take this or? I will try to answer Dr. Adnan. شوف, what I know إنه according to the trial بدوها يعني gradual increase starting from 5. Okay, ما هي حتى يعني نص حبة, half of the 10. Then they went up to شو اسمه, to 20, and they usually start before starting the whole brain radiotherapy. This is what I know.
For how long?
اي والله ما أعرف.
Okay. Actually, I'm not using it. My father used to have it 10 milligrams. That's why. Somebody will ask who told him.
كيف عرفت؟ The other thing,
they give it in the trial, if I'm not mistaken, if I remember correctly. I couldn't pull it up now, but I think for 24 weeks or something like this. So it is not short time. It is not short time after treatment.
and the other thing, as you know, no one is يعني it's not widely used. It's not widely used.
Really? Actually, it's the data showed good advantage for the brain metastases.
Yeah, but Dr. Adnan, since we opened the discussion about this now, the adoption of Momentin is still low even in North America, where these trials came from. But what about hippocampal avoidance? Do you use it in your practice if you do the whole brain?
I failed 3 times to control the hippocampus. Really, I felt that our CT scan bringing very nice shape, or even with fusion with the MRI to see the hippocampus, like in the studies where they draw it like a small banana in the brain. Really, it's not that easy to control the hippocampus. There's a lot of subjective things. It is not easy. It is not like the brain stem or the optic chiasm or optic nerve. It's something inside between the temporal lobe and the cingulate gyrus, which is not that easy.
All right.
So maybe we need to do workshop how to contour the hippocampus. Maybe we need workshop how to contour the hippocampus. Really,
Ibrahim can do this maybe later at some point. Why not?
Inshallah.
Thank you very much, everybody. It was a pleasure having you all tonight for this session. It was short, basically, and we tried to focus on the multiple brain metastases as opposed to the limited ones. Thank you very much, Dr. Ibrahim, and for all of you who attended this session. As I mentioned, we'll try to get the CME hours out of this session, but we're not 100% sure. But inshallah, in the future, our sessions will be credited by the Saudi Council for CME hours. And please fill in the form if you're interested to have the potential CME hours of this session. Thank you very much, everybody. And we'll see you, inshallah, next month. Ibrahim, any final remarks?
Thanks, everyone, for holding with us. Thanks, Dr. Adnan, Dr. Khalid, Dr. Yasser, and everyone else for your participation and active interactions. Jazakum Allah khair, and see you inshallah soon.